A complex cardiac surgery in the developed world comes with a price tag that frequently pushes patients into medical debt, pricing the average citizen out of life-saving care. Much of this cost stems from structural inefficiency. A typical Western cardiac surgeon performs maybe 50 complex surgeries a year. That means the operating room sits idle for long stretches, and the massive fixed costs of running a hospital are distributed across a very small number of patients. Dr. Devi Shetty proposed a different thesis: engineering a hospital to run like an industrial, high-volume assembly line. The Narayana Institute of Cardiac Sciences in Bangalore performs more heart surgeries annually than many entire U.S. states. They deliver these procedures at an 80 to 90% discount compared to American prices. Peer-reviewed data shows that even at these rates, their clinical outcomes rival top-tier Western cardiac centers. This financial summary describes a publicly traded, rapidly expanding global conglomerate. The top row shows 7,896 crore rupees in FY26 revenue, with operating margins of 21.7%. They have converted low-price healthcare into a consistent profit center. Inside the operating theater, the economics rely on extreme throughput. A single Narayana operating room handles upwards of 400 cardiac surgeries a year. When you process that many patients, the heavy overhead of running a facility, the machines, utilities, and specialized staff, gets divided across a massive denominator. The fixed cost burden assigned to each individual procedure shrinks to a tiny fraction. Because the per-surgery cost is low and predictable, Narayana offers packaged treatments. Patients pay a single, transparent fixed fee that covers the entire medical journey, from the initial diagnosis through post-operative care. A competing hospital cannot simply lower prices to match this. Without the same patient volume to spread out costs, slashing prices leads to a loss. That operational intensity creates a structural moat. Expanding a hospital chain typically requires significant capital expenditure to buy land and construct massive, specialized, code-compliant buildings. Narayana avoids this bottleneck through an asset-right strategy, deliberately decoupling the business of delivering medical care from the business of owning property. They operate facilities in 4 distinct ways. They own a few flagship buildings, but they primarily lease buildings, pay a revenue share to landlords, or charge a management fee to run third-party hospitals. By letting partners hold the real estate risk, Narayana limits its capital cost to 2.55 million rupees per hospital bed. The capital they save on land goes into what directly heals patients: medical equipment and recruiting clinical talent. By operating as a healthcare provider rather than a real estate company, they expand their clinical footprint while maintaining high returns on invested capital. Beyond physical infrastructure, the company is moving to control the payer ecosystem. They recently launched a direct-to-consumer health insurance business designed to eliminate traditional insurance brokers and distributor middlemen. While this insurance segment is in its early stages and currently recording a loss, management views this as a deliberate customer acquisition cost. Without middlemen taking a cut, Narayana passes those savings to patients through lower premiums. This creates a multi-touchpoint relationship with customers, securing a predictable revenue stream for the core hospital business. The final pillar of this model is geographic arbitrage. Narayana takes its Indian clinical processes and exports them to markets with high healthcare costs. Their facility in the Cayman Islands was built as a medical tourism hub for Americans and Canadians seeking lower costs for orthopedic and cardiac procedures. This financial breakdown shows the impact of that strategy. The Cayman operation generates US dollar revenues at EBITDA margins of 35 to 40%. It serves as the primary profit engine of the group, with regional revenue growth of nearly 60%. In the United Kingdom, they acquired the Practice Plus Group to tap into stable, long-term government contracts with the National Health Service. To increase those UK margins, Narayana utilizes their Indian back-office software and shared technology services, reducing the structural overhead common in Western administration. Narayana Health shows that affordable healthcare functions as a defensible, scalable business blueprint. By centralizing volume in the OR, deploying an asset-right real estate model, and utilizing geographic arbitrage, they have created a model for high-margin, low-cost delivery.